I just finished my prosthodontic residency. I'm moving on to periodontics. I think it's a great time to be in this field, considering all the digital workflow, the amazing things prosthodontists do in conjunction with the surgical team. I think it's really life-changing. The reason I chose prosthodontics is because I was doing a lot of general dentistry. I felt the need to make some life-changing treatments for my patients. And as a general dentist, I think I was having a hard time doing those. So I just took a complete turn and went back to school and then started my prosthodontic residency. And I think that's the best decision I've ever made. And I congratulate all the residents there because I think you're very young. I think you've taken a great step forward. Having said that, I'm going to go ahead and get started. This is probably going to be a two-part series. It's just very extensive topic to talk about. So I will go ahead and probably present half of the cases and then we can move on to the rest. I'm not going to talk about a lot of literature. I know you guys do a lot of literature review. So I do want to make it more like clinical based where I can share cases, more or less like all the cases which I have seen in the prosthodontic training. And I do want to share those with you. That way I can let you know what we learned through the process, and then I'm hoping that it'll be a good learning experience for you. So I don't have a lot of literature in this series itself, but if you want references and things like those, we can always put together another kind of component towards it. But this is mostly clinical based, so I hope you'll like it, and I hope if you have any questions towards the end of it, we'll have some time for question and answers. All right. So my topic for today is evaluation and restorative driven implant planning and complex prosthodontic rehabilitation. I was glad to know that Dr. Nirmal Kurian had mentioned that as a wonderful facility in the northern part of India, you are doing a lot of implant restorations. But the question is, what he said is you want to kind of take it to a different level where you want to give that quality of care. And to give that quality of care, it's very important to kind of understand and evaluate these cases on a daily basis, kind of in-depth, understand it from the beginning, from the time the patient walks into your clinics till the time you finish the treatment. So I think that's what differentiates you from somebody else outside trying to place implants, because I'm sure you see a lot of implants being placed outside. Same here in the United States, there's like 1 million implants that are being placed outside. But what actually differentiates a specialist from somebody else outside who's placing an implant is the part where you're evaluating, diagnosing, treatment planning, and executing your treatment planning. I think that's what has to differentiate you from somebody else who's actually placing implants on a daily basis. So having said that, I'm just going to go ahead and move on to my slides here. So what is challenging about these complex prosthodontic rehabilitation? Why do we talk so much about these complex prosthodontic rehabilitation? Well, 3 things to remember is the most critical element of predictable treatment outcome is treatment planning. As prosthodontists, that's what we do. I mean, I was placing implants day in and day out, but what I did not understand is the treatment planning, the sequencing. And as a prosthodontist or as any clinician who is dealing with these complex full mouth or complex prosthodontic rehabilitation, diagnosis and treatment planning is the key. So again, having said that, if you fail to plan, you certainly will plan to fail. And the third part is accuracy, speed. Speed does not necessarily mean it's accurate. That means a lot of these patients who come in, they want to do things quickly. They want to have everything done within a day, 2, 3 months. But if you do it more accurately, that is speed. Basically, that's how you're progressing forward more faster than trying to get things done on a daily basis within a day or two. That doesn't necessarily mean like things are accurate. So as far as failures of these large prosthodontic cases on a daily basis, the ones that we see here, unfortunately, in the PROS program here, we do a lot of redos, a lot of implants that have been placed outside, which cannot be either restored or need to be removed, or we need to come up with a complex design to try and restore them. And I'm sure you've seen a lot of those as well. And this primarily comes because there was not enough treatment planning or diagnosis, or that step was missing before the implants were placed. So rather than jumping into direct implant placement, the first thing is to diagnose the case, treatment plan, sequence, understand what are the complications, and then go ahead and place the implants. I think that makes your cases more and more successful with time. So as far as prosthodontic failures, it could be biological, mechanical, and aesthetic failure. What that means is the implant can be in a very good location, but if it's not biologically healthy, that is a failure. Similarly, it could be very well integrated in bone, but if your prosthesis does not have that kind of material thickness, if the angulation is too severe, it can cause mechanical failure, that is screw loosening or probably fracturing of screws, fracturing of prosthesis. And finally is aesthetic failure. It might be successful for you. That means the implant might be in a great location where there's adequate bone all around the implant. Biologically, maybe you came up with a design that works just fine and the screws are nice and secure. But if you're not able to attain aesthetics for the patient, that is a failure too. So if you think about most of these complex cases, you want to consider these three factors. That means you want them to be biologically successful, you want them to be mechanically and aesthetically successful. So when you're dealing with all these cases, you need a team. Basically, the team comes from a surgeon, a prosthodontic or a restorative provider, and obviously the lab is a very important component of what we do on a daily basis. It's very difficult for you to accomplish or have a predictable and a great result by doing everything on your own. And as a prosthodontist, I would do a lot of my own surgeries. And the reason I'm doing perio is because I'd like to do a lot of soft tissue grafting. I want to have more predictable results for my patients. I want to have a greater outcome for my patients. And that's the reason I'm doing periodontics. But even after periodontics, there's not a lot of cases that I can do on my own. I will need to have support from either an oral surgeon, other colleagues, orthodontists, and so it's basically like a team approach when you think about these complex cases. So you want to be in a situation, in a scenario where you're working with different specialists, trying to manage these complex cases. And this is the best thing about being in a university or a school, because you have all other departments. You have every specialist in that building, basically the best in what they do, and you can all come together and then make these treatments very successful for patients. So I want to show you some of these, patients who come to us on a daily basis. Most of these implants have been done outside, but I want to show you what kind of failures these are. So this is a 21-year-old male patient. Implants were placed about a year ago, and the outside provider had provisionalized the implants and then sent it to us because the patient wasn't happy with the aesthetics. Of course, if you see he's a good-looking young man, if you see the lower anteriors, the three anterior teeth have been replaced with implant provisional or temporary teeth. And if you see intraorally, this is the outcome that he had after the implant placement. So what you see here is you not only see an aesthetic failure, but also biological complication where the implants are placed too far facially. There's no soft tissue. And obviously the level, if you see the adjacent teeth, they're much higher, or the gingival zenith on those teeth is much higher than where the implant is. So these are things, or these are cases which really need a lot of treatment planning. If you do not plan these cases, you are certainly going to end up in situations like this. It's easy for us to jump ahead and place implants right away and try to figure out the restorations later on. But if you try to do that, you're going to frequently end up in complications like this, and then you're going to have to keep redoing cases. I mean, imagine redoing a case like this on a 21, 22-year-old. It's not great. You're still not going to be able to get a great outcome. Similarly, had a patient that came in, implants were placed outside. This was for an overdenture. You see the ridge is very atrophic, very resorbed ridge. But if you see that implant on the lower right side, it's placed way far facially. There's no keratinized tissue. It's pretty much out of the bony housing. And if you think about trying to set up teeth for your denture has to be really bulky in that area, trying to manage or cover that implant, or even to try placing a locator. Sometimes you can't even use these implants. Unfortunately, after the patient went through all this treatment, you have to either explant them or just bury and leave it, and basically they're of no use. So what I'm saying is, if you do not plan these cases, you are frequently going to end up in complications like this. This is another case with zygomatic implants. Of course, everything is well integrated in bone, but if you look at it, none of them are in a great position, right? You see, this is pretty much coming out of the mandible, the maxillary implants. These are zygomatic implants. They're all coming from different angles. So intraorally, this is what they look like. I mean, trying to restore these is a nightmare. You cannot restore this and have a prosthesis where a patient can easily clean them and also give them aesthetic results. So basically, whatever you're doing from here onwards is either you tell the patient that you cannot restore them, or you pretty much giving them a suboptimal care where you know that patient's not going to be able to maintain it or it's going to fail over a period of time. So how can we rectify these cases? If we were to see these patients before these implants were placed, of course, you can have a planning. You can have the surgeon help you place implants in a more predictable location where you can actually use them or have better service for the patients. Similarly, these are some of the implants that were placed outside. If you see these three implants placed on the upper right side, they're very close to each other. You can also see that they're pretty much out of the arch. So trying to restore these, I mean, of course, you can try and do some kind of cement retained restoration, but not the most ideal. Whereas if the patient came to you ahead of time, you can easily do a simple wax up on here, do a CT scan based on that wax up, give the surgeon some kind of a guide or at least some kind of a position where you want those implants to be, and you can pretty much restore these very easily. These can be simple cases if the implants were placed in the right location. But once they are placed in these complex locations, it actually becomes a very difficult case. So there's another patient, high smile line. Of course, when you have patients with high smile line, these can be challenging. This is a patient who was being sent to us to try and restore these implants that were placed in the maxillary arch, because halfway in the treatment, they realized that they couldn't give her an aesthetic result. So if you see the implant in that lower upper maxillary anterior area is too far facial, and this is provisional or polymethyl methacrylate provisional, a full arch provisional. And if you see, once the provisionals were removed, this is what the implant looked like. It's so far facial. Imagine trying to restore this. The patient has undergone extensive treatment where she has 7 implants, spent all this time, money, and effort. And when they come to you, you cannot restore these. These are way too far facial. Even if I tried to do a cement retained restoration, there is no way for us to have an aesthetic result on somebody who has such a high smile line. So these poor implant angulation can complicate your life, and obviously the patient will not have a great outcome. So after we made an impression, this is how severe the implant angulations are. Whereas if you had this patient come to you before these implants were placed, you can actually do either a denture setup or some kind of a tooth setup, get a CT scan, and then give a surgeon some kind of a reference where you want those implants to be, and make your life a lot more easier trying to restore these cases. So these are the cases that you are actually going to see as a specialist. A lot of these simple cases go outside to general dentists or other clinicians, but as a specialist, you are going to be seeing complications, basically trying to manage them. So my goal is to kind of train everybody to help do these cases in a more predictable fashion, where you have some implant planning, some kind of a diagnostic setup, and then go ahead and restore these on a daily basis. So this is the patient after the new provisionals were placed, but again, it has to be some kind of a cement retained restoration. The midlines are a little off. So when your implants are actually in those locations, you really don't have a lot of control over aesthetics. So you try to do the best you can. So as far as keys to a successful prosthodontic treatment, one is, as I kept telling you, diagnosis. As soon as the patient comes to your office, the first thing is making sure you get all the records. You sit together, take pictures, take x-rays, diagnostic casts, and things like those, determine the right vertical, and then go ahead and put together a treatment planning. Once you get a treatment planning, you need to sequence your treatment planning, how you want to go forward. Then you do want to have some kind of a diagnostic setup, which can give you a predictable position for your implant. After you get the diagnostic wax up, then you could probably go ahead and get your CT scan, do your implant planning based on the CT scan, and then provide your surgeon. Or if you plan on doing the surgery yourself, you could have some kind of a guide. It could be a soft tissue guide, it could be a hard tissue guide, it could be a stackable guide, any kind of a guide, but at least something that can give you a reference where you want your implants to be. Finally, you also want to determine what kind of restorative material you want to restore these big cases. If you're doing a full arch case, If you plan to do zirconia, say for example, you need to have adequate thickness. That means your implants need to be at a certain depth. If the implants are shallow and if you do not have vertical height, you are going to end up with broken prosthesis. You're going to end up with other complications. So you need to make sure you have adequate restorative material thickness. And finally, the most important part is to maintain these big cases. After patients spend a lot of money, a lot of time to get these big cases, you don't want to redo them. As a specialist, you want to help them maintain it through continuing care. So I would say these are some of the keys to a successful prosthodontic treatment or rehabilitation. So I do want to go over some of these clinical cases that I've seen in our department. Somebody who's come in with a vertically maxillary excess. Patient comes in, she says, I don't like my smile. I really feel like my teeth are broken down and I want to get implants. So from here onwards, as soon as the patient walks into your office, you can tell that this patient has a vertical maxillary excess. So if you see the patient, she has a very high smile line. This ideally has to be a Lifford 1 orthodontic kind of a procedure. But if you're not able to do it at that point of time, patients don't want to go through that kind of surgery. Now, implants is one option, but what are you going to do? She's a 48-year-old patient. Are you going to take away all that bone and then give her more like a long prosthesis? Or are you going to be a predictably treatment planning in a way where you can give her more of a crown and bridge kind of a prosthesis because she has a very high smile line? You need to think about where my implants have to be, how my pontic sites have to be, and things like those. So these are very critical when you think about these cases which have very high smile line. Similarly, a patient with a skeletal class 2, if somebody comes into your office like this, patients like, my teeth are all broken down, I need to get implants. So you don't want to jump ahead and place implants right away in patients like these, because this is not where you want your final restorations to be. You want these patients to have a better aesthetic outcome. That means the teeth position needs to be changed. The vertical height needs to be modified. So you need to understand all these things and plan all these ahead of time, and then proceed with the implant placement. So as far as guides, there's a variety of guides. I don't want to go over a lot of depth in terms of what kind of guides, but this is basically like the similar patient who came in with that implant that was placed outside the arch on the lower right side. You could make an overdenture guide like this and give it to the surgeon, where you can pick up those implants with locator housings, and then you can snap it in place, and now the surgeon has something to work with, and then this can help them place an implant in the right location, and you can use it for the right purpose. Similarly, you can do other stackable guides. I mean, these are simple guides that you could do. I don't want to go over very complex guides. We have complex stackable guides that you can work with, but these are very simple guides that you can actually do it in your office and provide it to the surgeon, and then have them place implants at the right locations. That way it makes your life a lot more easier when it comes to restorations. So these are stackable guides. This is a base guide on the top, and then the implant guide or the bone reduction guide can get or snaps onto it. This is how it fits in the mouth. Basically, this is a base guide which fits with the help of anchor pins. It has some slots, and in those slots, you can put in your bone reduction guide or an implant placement guide. And finally, implant planning is obviously important. Once you have, this is a patient who needed fixed prosthesis in the maxillary arch. We went ahead and made a denture first, and then, did a CT scan with the denture, merged the denture or the dual scan with his CT scan, went ahead and planned implants. And once the implants were planned, we went ahead and fabricated surgical guide. Similarly, this is a tissue bone guide, which kind of is held with the help of some anchor pins, and then you can place implants. And then finally, you can predictably start these cases and make your life a lot more easier for yourself and for the patient, as long as the planning is done. So this is the planning on the top, and this is how it's been completed, and this is how it was immediately loaded. So if you think about this, from starting from here, planning to where actually it ended up, it's very similar. The only reason is because you had some kind of a reference to go by with. This is another case of an ex-snab. Patient came in with periodontally compromised teeth. Obviously, you don't want to extract teeth and place implants right away, but you want to try and establish the right occlusal plane, the right incisal edge, the right lip position, and things like those. So this is what it looks intraorally. What we did is we went ahead and did an intraoral scan. These are his STL files. This is how it looks when the casts are mounted at centric. And then we went ahead and did a digital wax up for him where you can actually try and reposition his teeth, because when you place an implant, if you are asking the surgeon to go ahead and extract and place the implants without providing where you want your future teeth to be, obviously it's very easy for anybody to extract those teeth and place implants in a location where they can be way more facial, and you can end up in situations like I showed you before where the implants are so far facially placed that you cannot pretty much restore them. So in these cases, you want to have some kind of a reference where you want your final restorations to be. So basically, this is overlaying of the final tooth setup. This is done with XNAV. This is one kind of a guided system where you have the base guide that gets anchored onto the teeth, and this is the pickup prosthesis. This is what it looks like. Again, you get a base guide. This is a pickup prosthesis. You have a backup denture just in case if your implants do not have adequate stability. But this is how it fits. So you have a base guide, and this is an X-snap clip. It fits onto the teeth. You can secure it. And this gives a surgeon a better idea of exactly how deep you want those implants to be. In this case, the plan was to do zirconia. That means from the place where you want to have your incisal edge to the location of your implants, you need certain amount of thickness, typically about 12 to 15 millimeters. If you do not have those, if the implants are placed more shallow, then you won't have enough restorative material thickness. Again, this is a case that I showed you earlier, somebody who has excess gingival display. This is what it looks like from the side profile. So rather than stepping ahead and placing implants, what we did is, this is an intraoral view of the patient. In some cases, you cannot do a try-in. If it's a denture, then of course you have freedom to try in the teeth wherever you want. But in some cases, you just cannot try those teeth in. So you can digitally do a virtual tooth setup where you can estimate or guesstimate where your teeth should be in 3D space. And then based on that, you can go ahead and plan your implant. So this is a patient who came in with a high smile line again, needing implants. Most of the teeth in the maxillary arch were non-restorable. The mandibular arch had a lot of wear. The mandibular arch, most of the teeth can be restored, but in the maxilla, unfortunately, she had to lose all the teeth. But when she came in as part of the diagnostic setup, along with everything else you do, basically what we did is we want to establish where you want the incisal edge to be. So in a patient like this, you do not want to chop off all the bone and give her a prosthesis to hide the tissue junction. If you plan on doing some kind of a fixed prosthesis, which is more like a crown and bridge design without any pink, you want to make sure your implant depth is very accurate. So what we did in her case is we wanted to reduce the incisal edge because her display was way too much, and we wanted to lengthen the teeth. So if you see this contrast, this is the natural tooth, and this is where some of the bisacral kind of a diagnostic mock-up was overlaid on top of her existing teeth. That way it kind of simulates. So basically, we want these implants to be 3 millimeters from where my final gingival margin is. So if I were to place implants based on this tooth setup, my implants wouldn't be very deep. They would be very shallow. So this is a key for these big cases. So what we did is, after we prepped some of the teeth, because those anterior teeth were anyway, some of them we wanted to save them. But this is what she looks like when you did a tooth setup, this is a diagnostic mock-up rather. So some of the teeth were prepped, and then we went ahead and printed a digital setup and then tried it on. And from here onwards, this is what it looks like basically in the mouth. This is extraoral. So if you see, there is two margins here. One margin is where her current gingival margin is, and this is where you want your final design to be. So your implants should be actually 3 millimeters from this top margin. So this is how it fits in the mouth, and based on that, as you can see, this is how deep you want the implants to be. In her case, we decided after we prepped the anterior teeth, they were not too bad. She was a young patient. We decided to save these anterior teeth. So based on this guide, we went ahead and got a crown lengthening guide, did crown lengthening for her. And then after the crown lengthening was done as phase one, we used some of these fiduciary sure point markers, scanned her, and then used the same setup and then fabricated a guide. So this guide actually sits on her preps, as you can see here, and then it has implants that were planned in the exact location based on where the gingival zenith of these posterior teeth are. So for example, this is where I want my final restorations to be. My implant has to be 3 millimeters deep from this future gingival margin, not too deep, not too shallow. These cases are very tricky because these are high smile line cases. You have to be really right on as far as aesthetics. Otherwise, you're not going to have a very good result. These are really tough cases. So you want to have a very thorough treatment planning for these patients. So this is a guide that sits on the teeth. And then once that's done, you go ahead and place the implants at the right depth. And basically, this patient is still in treatment, but more or less, this is how the sequence goes. Once these implants integrate, basically, we already finished the crown lengthening in the anterior teeth, and then the posterior implants are placed at the right depth. We go ahead and provisionalize her and then finalize everything in the maxillary arch and then start working the mandibular arch. This is the other patient that is skeletal class 2. Again, a little bit of a high smile line. As you see, she's large vertical. Her anterior teeth are very proclined. This is the intraoral view of these teeth. Again, you want to establish the right incisal edge position. So right now, these teeth are way too supraerupted. You don't want to build her to this existing occlusal plane. So you want to determine the incisal edge position. And in some cases, you don't have a choice than to extract these teeth, put her in denture, and then implant and do the implant planning. Yes, it takes longer. Yes, patients have to go through a removable prosthesis, but if you explain the patient that this is the right way of doing it, and this is the only way where you can predictably have a good outcome, patients will understand. They are willing to wear a removable prosthesis for 2 or 3 months versus having implants placed in the wrong location and then living for the rest of your life with some kind of a removable prosthesis, because those implants cannot be used for a fixed prosthesis. So kind of explaining the patient is also an important or a key part to this process. So this is what she looks, or her teeth look like infraorally. Obviously, a lot of the maxillary teeth cannot be restored because we couldn't really do a try-in, and some of these anterior teeth had periapical infection, decided to extract the maxillary teeth and then do it in 2 phases. The bottom or the mandibular teeth were periodontally compromised, supraerupted. So we also had a backup denture for her. And in some cases, when you can actually save a few teeth, that's great, because we all know that tooth-supported guides are much more accurate than tissue-supported guides. So if you can save a few teeth, that's great. In this case, we did have a freedom where we could save a few teeth. So this is a guide that's fabricated on the existing teeth. So digitally, you can actually remove some of the teeth, keep the teeth that you want, and then fabricate a guide that actually sits on the teeth that are away from your implant. So this is what it looks like in the mouth. So, went ahead and made a mucoperiosteal incision, seated the guide. The guide sits on the back molar that we have here and a few anterior teeth. And then that way the guide is very stable. You don't have to have any anchor pins. You don't have to have any errors in a case like this, because these are tooth supported or tooth bone guides. Those are a lot more stable versus some kind of a tissue bone guide. So this is how the implants fit in. And then finally, we want to make sure everything is lined up very well. So this is exactly how it was planned. And basically, you can go ahead and immediately load it. And you know that the implants are placed at the right depth, the right location. Similarly, in the maxillary arch, as you can see, she has a very high smile line. So if I were to place implants based on where her existing teeth were, she would definitely show this tissue prosthetic junction, which is not successful. That's a very poor treatment. So at this stage, once the mandible was immediately loaded, maxillary extraction sites had healed. We went ahead and marked an area where we need to reduce this bone. In this patient, she did not want to go through an individual crown and bridge. Instead, she wanted to go through a hybrid prosthesis. So we went ahead and asked her to smile. We marked those areas at the time of surgery with the perio probe. And then based on the guide again, we went ahead and placed the maxillary implants, did the bone reduction. And this is still in provisionals. Right now, she's still in treatment. The implants are still healing, but this is what she came in with. As you can see, her incisal edge position is completely modified, has been modified. Aesthetically, it still needs a lot more improvement, because these are just provisionals or your denture that has been picked up after the surgery. But in the next set of provisionals, she's going to have much better aesthetic outcome, and then you can carry that onto your final prosthesis as well. So having said that, if the patient came in and if I were to extract these teeth and place implants right away, I might not be able to place them at the right location or the right depth and might not have a good outcome. So once again, I cannot emphasize enough treatment planning, diagnosis is the key to these cases. This is another patient, history of ectodermal dysplasia. He came in because he was wearing a partial for almost like 20, 25 years. He's a professor. He was not pleased with his smile for a very long time. He couldn't afford treatment, but finally he said he's ready to move forward with treatment. This is the intraoral view. He was wearing an overlay partial. These are deciduous canines that were holding a partial. As you can see, these incisal display is too much. And this is what his mouth looks like intraorally. This is the occlusal view of the maxillary mandibular arches. Some of these had mobility of the deciduous teeth, and in the mandibular arch, history of ectodermal dysplasia. So as you can see, a lot of agenesis. Most of the permanent teeth are not erupted. Rather, there are a lot of deciduous retained teeth. Patient wanted to have more of an aesthetic outcome. So in this case, similarly, again, we went ahead and did all the diagnostic setup. This is a diagnostic try-in. Again, sometimes you are able to do kind of a mock-up with the existing teeth, but in other cases, you don't have a choice then to extract. If these teeth were too extremely positioned way too forward, there is no way for us to do a mock-up. In those cases, we have to extract the teeth, put them in a denture, and then do the implant planning. But in this case, they were a little bit protruded. The incisal length was a little bit longer, but we were still able to kind of get a decent wax up or a diagnostic wax up. So this is a diagnostic wax up. After the wax up was done, everything is imported into software, and basically based on this location of the teeth, we plan the implants. And once the implant, this is another case that was done with XNav or XGuide. So we kept some teeth. I don't know if you're familiar with XNav or an XClip, but again, that's a very vast topic, so I can go over it another time. But in this patient, XNav also has a clip that actually clips onto the teeth that has some fiduciary markers, and it's basically dynamic navigation guided surgery. But because all the teeth were being extracted, instead of using the clip itself, we used this kind of a device that was 3D printed, and it was anchored onto the anterior teeth that we were planning to save. So this is what it looks like in the surgery. This is the tracker, and it gets anchored onto the teeth here. As you can see, there's some fixation screws that we can place, and then kind of this makes it very secure. And this is the wax up that we tried in. As you can see, some of these implant angles, and then we can easily place those implants in the areas that we want. In the mandible, because we had a freedom of keeping a few teeth, we went ahead and saved a few of his natural teeth, just like before. And then we went ahead and placed implants for him, and this is what it looks like. Final plan is to save some of these teeth. For now, implant restorations bilaterally, and in the mandible, we went ahead and extracted all the teeth, and then placed 6 implants for a fixed prosthesis in the bottom. And this is still in provisional. He's not in his final stages yet. Most of my treatments are still ongoing. So this is the provisionals. As you can see, you've completely changed the occlusal plane. You reduce the incisal display, more aesthetic outcome. And once you have the implants very, very well integrated, you can make more changes in your final prosthesis from here onward. So starting from where the patient came in from here, we basically made some changes to his existing occlusion, his existing incisal edge, and this is where he is in provisionals. Now, I want to finish up with this case that was referred to me. This was a patient who had 12 implants placed outside in private practice. And unfortunately, the implants were in very acute angles, and the patient has a low FMA, very heavy bruxer. She was breaking her dentures, and the clinician was worried about those implant angulations, so they went ahead and referred her to a prosthodontic department. So when I saw her in 2022, this is what she looked like. She was wearing a denture, and this is a frontal view. And this is the intraoral view of the patient. The patient has six very well integrated implants in the maxilla, six implants in the mandible. But the challenging part is very limited occlusal space. As you can see, I mean, this is closed mouth, but if you measure the distance from the alveolar crest of the maxilla to the mandible, this is very minimal space. I mean, trying to fit maxillary and mandibular restorations in a space like this can be a nightmare. Uh, so once the surgery is done, the implants are integrated. Now, as a prosthodontist, you're dealing with these complications. The patient is going to keep coming back to you that your prosthesis is fractured, um, or or they don't have a great outcome or aesthetic outcome. So this is how severe the implant angles are, as you can see, the anterior ones especially. So I went ahead and did a closed tray impression technique for the patient because I couldn't do a splinted impression coping because the implants were very severe and severely angulated. In the mandible, the implants were fairly straight, so I was able to do an open tray impression in the mandible. And once we did the impressions, we went ahead and verified the master cast, made sure the prosthesis was kind of passive. But if you see, these two implants were very severely angulated. There's no way for us to have something which is very passive with such severe angulations, more than 30, 35 degrees. I mean, you can have or you can work with angled implants, but you need to have the space. You need to correct them with multi-units. Obviously, it was not planned in this case. Maybe the clinician thought that the implants can be placed, and later on we can place multi-units. But if you don't have the space, multi-units are going to be, if you have a 30-degree multi-unit that comes with on 2 to 3 millimeter height, that's taken away your restorative space as well. I didn't even have space to set teeth after we did jaw records for the patient because we had to start off pretty much like a denture setup for her. We went ahead and digitally mounted this. I went ahead and did wax up at that point of time. This is the final wax up that was designed, and we milled prosthesis, PMMA prosthesis. I went ahead and fabricated a transfer guide. Now, this guide helps me uh, maintain the occlusal relationship when I'm picking the provisional. So it actually fits onto the provisional. So it's basically precisely fits. So it's two parts. These are both milled. You can also print them, provided your printing resin will not shrink a lot. So it fits onto these two, and then you can easily pick up these provisionals on the cast and then do all your adjustments and make it a lot more easier and deliver in the mouth. So this is the maxillary mandibular provisionals. As you can see, the implants in the anterior are two facial. This is what it looks like, the provisionals. This is the occlusal view. Unfortunately, in the occlusal view, as you can see, I had to split the prosthesis in between 8 and 9, or anterior, the two central incisors. The reason is because the patient kept coming back because the screws were getting loose. My prosthesis was not passive, so I had to split it in the middle. But the patient wasn't very happy because she had saliva coming through it, she had air passing through it, and she did not want that space in her final prosthesis. So it becomes very difficult for you to manage cases like these. This is what she looks like after the provisionals were delivered. Now I know that this is where my final teeth need to be. Now I need to worry about how I can use these existing implants. Sometimes you have to bury some implants. Sometimes you have to explant some of them. But anyway, this is what she looks like in the frontal and profile view. Once we had the teeth established at the right place, once the patient was happy, I went ahead and scanned this through our 3Shape software. And as you can see, these two angles, especially these two implants, barely are, the angles are very severe and the space is very limited here too. So I went ahead and designed like a little table because I was trying to think what kind of restorative options will I have. So these are some of the options that you have for full arch cases. You can do multi-units, but you need to have the space. You can do a milled bar. You can do a segmental bar that can go from one side and then split it right in the middle. But obviously the patient did not want the prosthesis to be split in the middle. You can have a facial axis, not very aesthetic again. You can have a combination, or you can do some screw retain with the cement retain in the anterior. But again, with such severe angulations, having a passive prosthesis is very difficult. If you do not have a passive prosthesis, you're going to see complication as a prosthodontist. So my final go-to was to do custom abutments with some set screws. So I went ahead and designed these custom abutments. The beauty of these custom abutments is because they're all engaging by themselves, I don't have to worry about passivity of these. On those severe implant angulations, you can go ahead and get these custom abutments. And this is a guide that a seating guide that I designed. Once the seating guide is designed, you can use those seating guides to seat these custom abutments. Because if you have even a little bit of a discrepancy in the seating of these custom abutments, the metal framework that goes on top of it is not going to seat properly. So I went ahead and designed this seating jig. The seating jig seats all the custom abutments accurately. This is through the lab. We went ahead and after the custom abutments were seated, I asked the lab to proceed with metal framework fabrication. This is the wax up that they sent me. Once I was happy with the connector thickness, this is porcelain fused to metal because we couldn't do zirconia for her. It was the space was too limited for zirconia. And having a patient who's low FMA with such limited space, she will definitely fracture the prosthesis. So we didn't have a choice then to go with ceramo metal restoration or porcelain fused to metal restoration. So this is how the metal framework sits on top of those custom abutments. And the mandible, it's easy because these implants were fairly straight. So if you see a comparison between the mandibular and maxillary arch, maxillary prosthetic design is so much more complex than the mandibular prosthetic design. This is so much more easy. It's retrievable. All the implants are straight coming from the occlusal aspect. So a lot more easy to manage this versus something on the top where you have different angulations. So this is the set screws. This is the metal framework try-in. This is how it fits. These are the radiographs showing the intimate fit of the suprastructure on top of the custom abutments. This is a mandibular prosthesis, making sure everything is passive. And we went ahead and did a metal framework try-in. Again, these cases, you need to verify every single step. If you go wrong in one step, this work is really expensive. I mean, a lab cost for something like this, it's pretty devastating. If you have to redo any of these steps, you're pretty much going to be losing a lot of money as a clinician. So once I was happy with the metal framework, I verified the occlusal plane, the midline, the lip support. I went ahead and had the lab layer porcelain on top of the suprastructure or the metal framework, and then finish up those set screws on the palatal. So as you can see, the mandibular design is a lot more simpler than the maxillary design. Once again, the only reason is because the mandibular implants were so much more parallel. They were placed in very nice location compared to the ones on the top. And then we went ahead and verified everything extraorally before the patient came in. You obviously want to make sure the prosthesis has nice convex intaglio so the patient can keep it clean. This is what the tissues look like after the provisionals were removed. This is the maxillary arch that was delivered first because the set screws, you need to have space to kind of get in there. These are breed-in screws that kind of go from the palatal aspect. So I did not put the mandibular prosthesis first. That way I had more room to use and put these maxillary set screws in. This is the final delivery of the maxillary and mandibular ceramo metal prosthesis, frontal view, the right side in protrusion. Again, occlusion is very important for these patients. You want to make sure there's no contacts in excursive movements and ensure that you can check occlusion not only with the articulating paper, but also with shim stock. This is the right and left. Again, making sure there's no excursive contacts is kind of important to prevent porcelain from fracturing. This is the occlusal view of the maxillary arch. And then again, made sure patient is able to keep it clean through help of superfloss. As far as maintenance care, again, low FMA patient, you want to make sure that the patient is compliant wearing an occlusal guard all the time. And this is what it looks like in the radiograph of the maxillary and mandibular prosthesis. Again, periapicals showing all the prosthesis, especially the mandibular prosthesis, passively seating on all the 6 implants. And this is how the set screws fit in. You want to make sure they're all flush, otherwise the patient's going to keep having either ulcerations on the tongue or irritations on the tongue if they're sharp. And basically, this is the frontal view of the patient, and this is where we finished up. This is the profile view. And so having said that, I think I'm about 45 minutes. I try to zip through it, but as you can see, it's a lot of information. But this patient, we were able to finalize her prosthesis in porcelain fused to metal. If these implants were placed in a much what do you say, more parallel location had much more depth to them, it would have been easily restored with the help of zirconia prosthesis, and the cost of the treatment would have been half of what she ended up spending, because this is ceramo metal restoration. And I don't know how it is in India, but in the US, ceramo metal restoration is almost twice as expensive as trying to do something like this with zirconia. So again, all these big cases will need a lot of implant planning. And if you're able to diagnose these cases ahead of time, do your predictable wax up or some kind of a tooth setup, and then give the surgeon some kind of a reference, I think dealing with these cases and completing these three cases are going to be a lot more easier and more predictable. Having said that, I think I'll finish up. It's 45 minutes. If you have any questions, I can take those questions, and maybe if you guys want, I have the second part to it, and we can continue at a later stage. Thank you very much.
Thank you, sir. Uh, it's right now, like I know how much you emphasized on treatment planning, and if I want to say, I mean, I can say with a lot of confidence that over the last few years we have been able to do a lot more treatment planning. We have a CBCT now. We have a team where very good, good coordination. I will say we have Dr. Shekhar here, if you can see
Perfect.
him. So they help us with a lot of treatment planning with CBCT, which we never had for our own for the up before last year. And Dr.
Right.
Indrajot sir is also here. So yes, as a team, we are able to do a lot of things recently, but you are showing us where we want to be with respect to the quality of treatment. And with all right now we have better coordination, but yes, honestly, if you have to be very very honest with ourselves, sometimes we end up being lucky, I mean, and if you ask me, sometimes we are not planning what is the prosthesis that we are giving, maybe the restorative material, and that is what I'm feeling, at the beginning only we should have what is the restorative material that we should be giving with
Absolutely.
zirconia prosthesis or PFM materials. And right now we have a few theses also, which is going to be with guided surgeries and things like that. I'll just share. Sir, I'll request sir to share a few words.
Perfect.
Dr. Vinay, how
Dr.
are you?
Indrajot, good. Good to see you.
Yeah, few people are there with you now in your America. Eh?
Haji.
Dr. Gandhi
Yes, a lot of them
and
actually.
so good. It was nice to see you presenting such a good cases, and your cases are quite thorough. And we have been actually doing guided surgery cases. We are doing normal implants also. We are doing
Fantastic.
all-on-4 also. We are
Indeed.
doing OVDs, and there are various theses which are going now. We are actually going with the thesis with CA implants, that is calcium chloride dipped implants with 4 weeks loading.
Wow, that's amazing.
Yeah. So we are going to compare the bone loss, marginal bone loss, and we are also checking we can say the stability of the implant at the time and 4 weeks after the placement
Wow,
of the implant.
that's amazing. I would like to learn more about it. That's great.
No, no, it's a mutual. Actually, we also learned a lot of things. How you have prepared your cases, how you are doing your cases. It's quite excellent,
Indeed.
and it's actually a coordinated effort. I will
Absolutely.
say,
Absolutely. It's a team
because
effort.
yeah, because one person can't do anything, which is
No,
for a successful surgery to be done, we require a good treatment planning, as Dr. Nirmal has already told us about Dr. Shekhar. So he has quite been instrumental in planning our cases. And then
absolutely.
executing is done. Then we have a good team of prosthodontists. I am very proud of them. They are doing very good job, and since now it's 18 years I have been in CMC, and I feel very confident when I do my cases that I have a backup, good prostho backup, and
That's
good rehab they are doing. And
perfect.
I'm very happy to see you. Really, after so long years, you have
Thank you.
doing good work. God bless you,
Thank you
and I
very much,
wish you more success in your life. Thank you.
Dr. Indrajot. Yeah, I
So
would definitely agree with saying that it's a team effort. There is no way one person can do it. And I think the beauty of being in a dental school or a university is because you have, like I told you this, you have the best in every field. So you can easily work together as a team and keep the patient as a top priority. Providing the best care for them will need multiple specialties to come together and then execute that treatment.
I request if anyone has any doubts, this, I mean, you don't need to be formal, It is our own alumni here, and this is the best opportunity to ask whatever you feel like. Sir, I just came to know about something called as Rawson screws. Have you
Rosen's,
heard about it?
yes.
One of the lab was suggesting me to use it. So what do you think about it? I mean, what I could read and find out is
Yeah.
it claims to be less, there is less screw, screw mobility or
Right.
loosening.
So basically, obviously, implant companies, especially, I don't know how it is there, but everybody wants to cut down cost. It's an enterprise. So Rosen screws were developed because they want to eliminate an intermediary abutment. So if you were going to do a zirconia that goes directly to the implant without any kind of a tie basis, like titanium tie basis or an intermediary abutment, they use Rosen screws. The mechanism of the screws is basically, it produces some kind of a lateral forces that secures the prosthesis and keeps it in place. I have not done it, but I have seen clinicians outside who've done it. I don't think there's long-term studies on how passive the prosthesis is. So I'm really not sure on a long-term basis how it's going to work out. But I've heard them do outside. I've seen a few where the zirconia directly goes to the implants or the fixture level with the help of these screws.
Is it a fixture level or is it on the multi-units?
Oh, it's a fixture level.
Fixture level. Okay. Okay.
Yeah.
And sir, I mean, anyone has any doubts? I mean, that's what I would like to emphasize. Don't feel that this is a very formal meeting. You can ask, even if you feel that your doubt is very simple, you can ask.
Sorry, Nirmal, I'll take that back. That is to a multi-unit. The Rosen screws is multi-unit. Yes.
Yeah. That was what the lab
Yes,
people were
Rosen screw.
suggesting.
Without the tie bases, without a desk component tie bases on top.
Exactly. They wanted to avoid the tie basis. And anyone? We have Dr. Neetu here.
Hello.
Hi, sir. Sir, I had a doubt regarding that one case with excessive vertical dimension that you had shown. Are you
Right.
planning to retain those anterior teeth as
Yeah.
FPDs, or is that also going to be replaced with implants later on?
So initially, the teeth did not look great to begin with. So we just kept them because we wanted to use them as a guide. We wanted to use them as some kind of a provisional for the patient. But after the prepping the teeth, I mean, the patient is only 42-year-old. I've decided to save those teeth. So initially, we had extracted the two laterals and grafted those sites, and then developed the pontic there, hoping that we're going to place two implants in that area in the anterior. But after looking at the way the anterior teeth look like, I told maybe we could do FPDs. Maybe we could buy maybe 10 more years out of those teeth, and then in the future she can always convert them into implant retained restorations. But yes, my plan is to. I mean, as specialists, we like to save teeth. We go to extreme measures to try and save teeth. So we don't jump into extractions and we don't edentulate people. So I think, yeah, for her, we're going to be saving her teeth. So plan is to do FPD in the anterior, both sextants, and then in the posterior, she's going to have implant retained FPDs on both sides.
Okay. Thanks, sir.
So one more doubt that I would like to ask is, imagine if we have the same restorative space. So what do you think about a full zirconia prosthesis or a PFM ceramic metal prosthesis? I mean, leaving aside the cost factor.
The thickness of material, you mean? Or what do you?
Yes, sir. I mean, if you imagine if we have the same vertical dimension of the restorative space is same,
Yeah.
what is yes, sir.
If the restorative space is same, I mean, I think zirconia has pretty good aesthetics. The thing is with ceramo metal, I'm sure you know, layering porcelain is very challenging. You need to have a very what do you call an expert in layering porcelain to produce a very good result. Whereas with zirconia, it's a lot more easy. There, it's very easy to work with. You can, or anybody can actually stain and glaze and produce a very aesthetic outcome with zirconia. But whereas with porcelain, there's chances of porcelain fracturing, porcelain fused to metal if you don't layer properly. If you're using too much of a low fusing material and then trying to gain more aesthetics, placing more layers on it. And if it's not done properly, it's very technique sensitive, I would say, porcelain fused to metal. So more chances of porcelain fracturing. I think that's one of the drawbacks. So I think we see a more and more of zirconia being done, but primarily two reasons. One is obviously the cost. Two is as far as aesthetics, I think you can attain, good amount of aesthetics without a lot of labor intensive work. I would say that.
Okay. So one of the cases that we did was a fully zirconia processes on 8 implants. But even in that, the anteriors were layered. It is like, all the posteriors was monolithic and the anteriors still required layering because, they say that they won't be able to give good aesthetics with that.
Yeah,
So,
definitely.
so far it is doing well.
Yeah, we layer too. I mean, even most of our zirconia prosthesis, we layer on the facial, and then on non-functional cusp, we do layer them, the buccal and non-functional cusp. Yeah.
So like we are saying, we will have a second part to it. Sir has a lot of cases to show, and this will be a good, good opportunity for our residents to see the level of documentation. You'll see the emphasis on treatment planning, and it will be good for the entire team here to elevate our practice, into a much higher quality one. And thank you so much for sparing your time. I think it is midnight there.
No worries. No, when I started residency, I was very excited. Every time a patient would come in, I would jump into treatment right away. But with time, I've realized that I spend a lot of time with treatment planning, diagnosing, spending time explaining the patient everything. I don't go to the treatment until I'm actually satisfied with the whole treatment. I think that's the key to it. The slower you take that first phase, the better your final outcome is going to be. You're going to end up with a lot less complications. And I think patients do understand because you need to make them aware of, say, for example, if you want to do crown and bridge, what is the difference between crown and bridge versus trying to do a hybrid where you have to take away all the bone? So not everybody is a good candidate. Say, for example, the patient with the vertical maxillary excess, if I were to do hybrid on her with maybe like 4 or 5 implants, we had to take away a lot of bone for her. She's 42, 43-year-old. I mean, how long is my prosthesis going to stay? How long are the implants going to stay? Maybe 10, 15, 20 years. But after that, what is she going to be ending up with? Like, you know what I mean? So I think a lot of it goes into explaining patients like, okay, this is going to cost you more, but at the same time, this is the best treatment for you. And maybe the patient's not ready. And sometimes I have to refuse doing treatment because I don't think it's the right treatment that I can provide for her. So in some cases, I tell them, I don't think this is something that I could do for you because I don't think it's the right treatment for you, but I'm sure somebody else outside might be able to do it. But so sometimes you have to take a step back and say no, because if you know that this treatment is going to fail, then it's better that you don't be part of it. So something like that.
Thank you, sir. Abhi sir, do you want to say something?
Thank you very much. It was really good. And I think you emphasize the right thing is the treatment planning and the team effort. Thank you so much.
No problem. Thank you.
Okay, so we'll plan the second part soon. And I want to emphasize with everyone that this is not a formal this thing. This is just not for
please.
having a webinar. This
Yeah,
is so
I mean,
that
I did not want to have a lot of literature, but I wanted to have more clinical cases that, that I have seen. I mean, obviously all these patients are my patients, but I mean, if you want to see anything in particular, or if your resident desire to see something in particular, you can let me know. But if not, like I said, I'll keep it more clinical based. That way you kind of have an idea.
Sure, sir. Thank you, sir. We'll end the meeting today. Thank you so much, sir.
Thank you very much. It was really nice seeing you all. Good luck.